Okay, so I'm going to start going through some of the talk. If at any time you have any questions, do feel free to interrupt me. Just unmute yourself, or I've got the chat down in the bottom of my screen, so I can see if you put anything in the chat. So just feel free to interrupt and ask for clarification if you need. I'm going to turn my video off just while we're talking. So unfortunately, the person who was going to talk about critical care monitoring wasn't able to speak this evening, but she's going to give us a talk in a few weeks' time. So that means that this is a really good opportunity for us to talk about cardiac arrest. The reason I've chosen to talk about cardiac arrest with you guys today is mainly because we had an event of a cardiac arrest in theatre a few weeks ago, which a number of students were involved with and did an amazing job. But I thought it would be useful for all of you to have a bit more knowledge and understanding of what's going on in a cardiac arrest situation, both so you can be effective team members, but also so that you can be team leaders once you become anaesthetic officers. So that brings us on to really the learning objectives for this session. So by the end of the session, you should be able to describe causes of cardiac arrest in adults through an A to E assessment. You should be able to recognise heart rhythms associated with cardiac arrest using ECG. You should be able to use the Resus Council ALS algorithm to explain the management of cardiac arrest, know how to perform chest compressions, and recall the doses of adrenaline and amiodarone used in cardiac arrest situations, and know when to administer these drugs. So we're going to start with a little video. So I will just stop sharing that. And I'm going to play a video for you. Okay.
If we just allocate roles, then I think let's go for airway.
Great.
Yeah. Let's go for Keith. Are you happy to scribe and manage the defibrillation should needed?
Yeah.
That would be great. And then Yanni, can you do cannulation? Yeah, sure. Bloods, fluids. Yeah. Let's also go for swapping in and out with chest compressions as well. Okay. Brilliant. Thank you. Well, I'll see you later. Okay. Thank you.
Bernard, are you all right? Can I have some help, please? Can you put out a 2222 call and ask for the adult resuscitation team and bring back the resuscitation trolley? Can you take over CPR for me? I'm going to count you in.
Okay.
Are you ready?
Yeah.
Okay, 5, 4, 3, 2, 1. Can we carry on with 32 on the bag valve mask with the oxygen on? I'm going to attach the defib pads. Carry on with that CPR. In a minute, I'm just going to ask you to pause and have a look at the rhythm. Okay, just pause CPR. That's a shockable rhythm. Carry on CPR again. I'm going to charge the defibrillator. Can we take the oxygen away? Clear, clear. Carry on with that CPR. Clear. Okay, stand clear. Shocking now. Carry on CPR. I'm just going to move the bed. Keep going with those chest compressions. Bed sorted.
Bill, my name's Mandy. I'm the resuscitation team leader. What's happening?
This is Bernard. He was admitted here with chest pain and he found collapsed. He was in cardiac arrest. We've given him one shot with the defib.
So we're about a minute in.
We're about a minute in, yeah.
Okay, thank you. Right, so we've got good quality chest compressions going on 30 to 2. Isabella, I need to join us. Can you please take over the airway management, please? Thank you. And we've got Keith. Excellent. Defibrillation. Keith, we're about a minute in. If you can just check the timings for me, please. He's had one shock already. Bill, can you get me the patient's notes, please?
20 seconds until the next 2 minutes.
20 seconds till we're coming in. So at that point, Amita, I'd like you and Yanni to swap over within the rhythm check, okay? So we're going to swap over at that point. And Keith, I'm going to hand over to you to deliver the shot.
Absolutely. We're at 2 minutes now.
Stop CPR, please. Looking at the monitor, that's a shockable rhythm. Straight back on the chest, please. Over to you, Keith.
Lovely. I'm going to charge the defibrillator. I'm not going to shock yet. Remove the oxygen and everybody else set back. Charging. Head is clear. Bed space clear. Amita, in a second, I'm going to ask you to stand clear so I can deliver the shock.
Yep.
And then I'm going to ask you to immediately restart CPR. Are you happy with that?
Yep.
Stand clear. Shocking now. Restart CPR.
Excellent, thank you. Okay, so we're in a shockable rhythm, and that was the second shock delivered. Okay, so have we got those notes coming? Yanni, please, could you put up a 500 ml saline for that? Okay. Can you also take me some blood through venipuncture? I'd like an FBC, a UNE, a venous blood gas, and a glucose, please.
Yeah,
thank you, Bill. Oh, that's lovely. Okay, so this gentleman came in. You said it was chest pain that he'd got. Can we get a definitive airway in with this chap now, please?
Yeah, sure.
Let me know when that's done, please, Isabel. So with the history, I'm really thinking thromboembolic is most likely to be our most probable cause, but let's just investigate the others while we're at that. Temperature-wise, Yanni, what does he feel like?
Feels warm to touch.
Feels warm to touch. Okay, so thinking, Keith, about ruling out the H's and T's, unlikely to be hypothermia. Hypoxia, we've got the tube going in. We're going to connect that to 15 litres of oxygen. No overt signs beforehand. His stats earlier looked okay on the chart. Fluids are up. Thank you. That's lovely.
Andy, the tube is in, and I've checked the position on auscultation. End tidal CO2 is 2.3.
2.3, so we've got a good ETCO2 for this. So I would like asynchronous chest compressions, please. So continuous chest compressions. Can we support his ventilation, please, to 10 breaths a minute? So we've got the bloods off. We're moving through the H's and T's, Keith.
20 seconds until the next 2 minutes.
20 seconds to the next 2 minutes. Okay. Drugs, we need to have some drugs ready, please, in case. I'd like 1 milligram of adrenaline, Yanni, and 300 milligrams of amiodarone preparing. When we get to the next point, Amita, I'd like you to swap with Bill when we do the rhythm check to manage the CPR. And Keith, I'm going to hand over to you for defibrillation.
We're at 2 minutes now.
Okay, stop CPR, please. Looking at the monitor, we're in a shockable rhythm. I'd like you to deliver a shock. Straight back on the chest, please. Keith, I'd like you to deliver that shock.
Bill, continue doing CPR. I'm going to charge the defibrillator, but I'm not going to shock yet. Leave the oxygen connected. It's a sealed circuit. Charging. The head is clear. Rest of the bed space is clear. Bill, when the defib is charged, I'm going to ask you to stand clear to deliver the shock, and then going to ask you to recommence CPR immediately. Are you happy with that?
Yeah.
Bill, stand clear, please. Shocking now. Restart CPR. Third shock.
We need to give some drugs. So we need to think about 1 milligram of adrenaline.
Okay, so let me just share again my slides. Okay, so that was our cardiac arrest video. So what did they do well? Can anyone suggest anything that the team did well in that cardiac arrest? Either by unmuting yourself. So you should be able to unmute on your Zoom, or you can type in the chat. I'd like to hear at least 2 or 3 things that the team did well. Is anyone able to unmute? Tell me something. So the communication from Hasifa, thank you. Yeah, I think the communication was really good, wasn't it? Who's got their hand up? Feel free to unmute and say what they did well.
They started compressions immediately and they minimized interruptions between the compressions.
Perfect. It was really smooth, wasn't it? Yes. And Sharon and Hasifa have said that roles were clearly defined at the start of the day before the cardiac arrest took place, weren't they? Any other thoughts, or should we carry on?
Distribution of roles, like someone was on airway, then another person on CPR, it reduces on the interruptions.
Yes, absolutely. So it was good, wasn't it, that the people on CPR changed regularly so people didn't get tired, but they also made sure that someone was allocated at all times. And then Bonnet said that they were brainstorming possible causes in the 4Hs and 4Ts. Great. Matthews commented on the leadership, which I think was really good. And did you notice the leader, when she arrived, didn't touch the patient? She just stood back and took charge. And perfect, uninterrupted chest compressions. Great. So I think you've picked up all the main things, which means that my job today is very, very easy, because I think that you understand a lot of the key components. But let's go through. So this picture here shows the chain of survival. So this is something that's produced by the Resuscitation Council. And it basically says that, like any chain, we need every link in the chain to be intact in order for the chain to be effective. So in order for our patient to have a good outcome from cardiac arrest, we need to recognize it early, start CPR early, start defibrillation early if it's a shockable rhythm. And then following CPR, we need to do effective post-resuscitation care to ensure our patient has a good outcome in terms of their heart restarting, but also a good outcome in terms of their neurological outcome. So we're going to start with this first link on the chain and think about whether we can prevent cardiac arrest. So this quote comes from a report done in the UK where they investigated all the cardiac arrests that had taken place in a period of time. And they found that 73% of patients were unstable before they went into cardiac arrest. And they felt that warning signs that could have been acted on were present in 75% of cases. So what does that mean for us as anaesthetists? Well, anaesthetists are really well placed to help in cardiac arrest situations. Firstly, because we've got skills that are very useful to the team in cardiac arrest, such as advanced airway management, and we have a good understanding of patients' physiology, which is really important when we're thinking about the causes of cardiac arrest. And we also see the patient at many points in their perioperative journey when we can intervene. So for example, in the team brief, if the surgical doctor highlights a patient who's high risk, we can go and optimize that patient and reduce the chance they go into cardiac arrest. We can notice on the ward that a patient is unstable when we're pre-assessing and make changes to their management, which will change their outcome. But we've also got opportunities, even when the patient arrives in theatre, in the operating room, pre-induction and following induction of anaesthesia. And our actions at all of those times can help change the outcome for our patient for the better. So now we're going to quickly talk about the causes of patient deterioration and subsequent cardiac arrest. And as I'm sure all of you who've worked with me before know, I'm very keen that we use the ABC approach to assessing our patients in any emergency situation. So we're going to do the same today. So can anyone think and shout out any airway problems that if we leave them untreated will lead to cardiac arrest? Feel free to unmute and shout out, or just put your answers in the chat.
Hypoxia, which may be caused by maybe obstruction of the airway, or the tube is blocked and it's no longer delivering the right oxygen amount.
Perfect. So I'm going to flick over. So basically any cause of airway obstruction, as you've noted, leads to hypoxia, and hypoxia leads to cardiac arrest. So our airway could be blocked with blood, vomit, foreign body, a blocked endotracheal tube or tracheostomy. There could be infection or edema. So direct trauma to the face or to the throat can cause an obstructed airway. Epiglottitis, which is caused by Hib or Haemophilus influenzae. Pharyngeal swelling, or in anesthesia, something like laryngospasm. If we don't treat laryngospasm effectively, our patient can go into cardiac arrest. And similarly, patients who've got brain injury and a GCS of less than 8 have relaxation of their airway and can go into airway obstruction. So this could be due to a brain injury, or could be because we've pulled a tube out before the patient's fully awake and not supported their airway. And if the patient becomes hypoxic, that can progress to cardiac arrest. Perfect, so well done, guys. The next one is breathing. So anyone think of any breathing problems, or can think of how I might have classified breathing problems? Anyone want to pop it in the chat or shout out any breathing problems that can cause a cardiac arrest? So I've divided these into primary lung problems and secondary problems. Anyone want to shout any? Tension pneumothorax, perfect. Yeah, so tension pneumothorax will quite quickly lead to a cardiac arrest if we don't treat it. That's a really good one. Any others?
Chest trauma.
Yeah, chest trauma. So something like a flail segment, and the chest trauma could also cause a tension pneumothorax or a hemothorax. Tamponade. So tamponade, I would put more as a circulatory problem, but it can certainly cause a cardiac arrest. Yeah, fine. So I have divided breathing into, so bronchospasm from Hasufa. Yeah, very good. So cardiac tamponade, Robert, I tend to put in circulation rather than in breathing. So I've divided these breathing problems into primary lung disorders and secondary causes of hypoxia. So primary lung disorders are problems with the lungs themselves. So things like pneumothorax, hemothorax, infection, COPD, asthma. A large pulmonary embolus could easily lead to a cardiac arrest because there's massive strain on the heart by a saddle embolus, and pulmonary edema can also cause a cardiac arrest. But we, as Emmanuel has said, reactive airway disease, so things like COPD and asthma can cause cardiac arrest. And when I worked in casualty, we had a patient with COPD who went into cardiac arrest in the casualty department due to probably acidosis and hypoxia. So then the secondary causes of hypoventilation as anything that causes the patient not to breathe effectively. So this could be reduced respiratory drive, which may be due to drugs such as opiates, CNS depression, so anything that causes a loss of respiratory drive, or anything that reduces the respiratory effort or the force. So things like muscle weakness in myasthenia gravis or other neurological disorders, nerve damage that affects the phrenic nerve and therefore affects the diaphragm, or restrictive chest defects such as rib fractures or abnormalities of the chest wall. And if these things lead to hyperventilation, there can be accumulation of CO2 and hypoxia, which can cause cardiac arrest. So now I'm just going to play some lung sounds, and I'm going to start a poll with you. So can you see the poll? Has that come up on your screen? It's like a quiz. Can you see it? Oh, wait, if I press launch, hopefully you can see that. So I'm just gonna, I'm just gonna play you some sounds that hopefully you can hear. So on the quiz, you can say what you think this lung sound is. Can you hear that? Okay, so you've got about 5 more seconds to pick something. 10 seconds left. So you've had 10 of you voted, and there are 23 of you here. See if anyone else can vote. Okay, we're going to stop there. I'm about to end the poll. So that noise was a wheeze. So the reason we know that it's a wheeze is that it's polyphonic. So it's got lots of different pitches of note and sounds quite musical in quality. And it is also in the expiratory part of the respiratory cycle. So those lung sounds are quite useful. When I send you these slides, you'll be able to go onto that website and you can listen to lots of different lung sounds. So I'm going to stop that poll and I'm going to just see if we can do another one. So I'm going to relaunch it and play you another lung sound and you can see what you think of this one. And when you're ready, just vote. I can't see who's voting what. Okay, so I think that's enough. We've had 12 of you vote. If anyone wants to vote, I'm about to end it. I can't see who's voting what, so just feel free to have a guess. Okay, so we'll end that poll and I'll share the results. Hopefully you can still see my PowerPoint. So that second one was stridor, which is what most of you thought. So stridor is a high-pitched sound. It's characteristically in the inspiratory part of the respiratory cycle. However, it can be both inspiratory or expiratory, depending on the exact location of the narrowing. So wheeze is caused by narrowing of the small airways. So something like bronchospasm will cause a wheeze in asthma or COPD, whereas stridor is caused by narrowing in the upper airway. So that would be caused by something like laryngospasm, a foreign body, or something like epiglottitis. So stridor is an upper airway obstruction, and it causes that kind of whistling, high-pitched note. Great. So we'll close that. So then finally, circulation. Can anyone think of any circulation problems that would cause potentially a cardiac arrest? We've had one of them already, I think.
Hypotension.
Yeah, so any cause of hypotension would cause, could cause a cardiac arrest. Yeah, anything else? So toxins, so any toxins that directly affect the heart. Yeah, perfect. Thank you, Robert. So I'm going to divide the circulation problems. Yeah, massive hemorrhage. Perfect, Kazaron. So I'm dividing these into primary cardiac, so things that affect the heart itself, and then secondary causes affecting the vascular system. So what I have done is divided the primary cardiac causes into acute coronary syndromes. So that's a myocardial infarction. So in a myocardial infarction, there's some blockage of the coronary vessels that leads to death of part of the muscle of the heart. Okay, arrhythmias, hypertensive heart disease, valve disease, any drugs or toxins affecting the heart, or any inherited cardiac disorders, so congenital cardiac diseases. And then in the secondary non-cardiac causes of circulation issues, we've got acid-base electrolyte imbalances, which can cause arrhythmias, blood loss or hypovolemia, septic shock, hypothermia, asphyxia, so that's so strangling or loss of suffocating, and hypoxemia, so any cause of low oxygen levels. Fine. So now we're just on quickly to disability and exposure, and I'm going to do these a bit more quickly. So in disability, any D problem which reduces the GCS can lead to airway obstruction, and airway obstruction leads to hypoxia. So that can cause a cardiac arrest. So brain injury, any drugs that cause reduced GCS, hypoglycemia, seizures, and coma. And drugs and toxins can also lead to arrhythmias, and we would count those sometimes in the D section, drugs and toxins. So they are included, and obviously hypoglycemia I've mentioned twice there. And then finally, exposure. So hypothermia is a reversible cause of cardiac arrest, very uncommon in patients who are in hospital, usually a problem in countries where it's really quite cold, in patients, for example, who have been out in sub-zero temperatures, inadequately dressed, or at altitude, or related to drowning or submersion in water, and then hypothermia can be significant. And in exposure, we also count any other injuries. So these usually wouldn't cause cardiac arrest directly due to an E problem, but would act via an A, B, or C problem. So you'd pick them up earlier. For example, trauma causes bleeding, which is a C problem, or airway compromise, which is an A problem, which can lead to cardiac arrest. Anaphylaxis can lead to hypoxia, which is a B problem, or hypotension, a C problem. And infectious diseases can cause sepsis, which leads to shock or hypotension, and that can cause cardiac arrest. Okay, so we're through that. So we've talked so far about early recognition and call for help. So if on your assessment of a patient in a pre-op situation, you find someone who you are concerned has one of the conditions we've talked about in the last 10 minutes, that's someone you need to be escalating, and interventions need to be started that will reduce the chance of that patient deteriorating further. But let's say you've gone past that point and you've had the patient's gone into cardiac arrest, then really early CPR is key. And if we want to do early CPR, we need to recognize that there's a cardiac arrest quickly. So cardiac arrest is defined as the cessation, so the stop of spontaneous circulation and respiration. It's diagnosed when a patient is unresponsive with absent or abnormal breathing. So some earlier guidelines included absence of palpable pulse as a criterion, but reliably detecting peripheral pulses in stressful medical emergencies is difficult, because often people will be feeling for a long duration of time, thinking, can I feel the pulse or can I not? So the Resus Council in the UK certainly advises now that if the patient is unresponsive and they're not breathing, or their breathing is abnormal, so agonal gasping, then we should assume that patient is in cardiac arrest and commence CPR, because we know that delaying onset of CPR leads to worse neurological outcome, even if we manage to start the heart again. So why do we bother doing CPR? So we've already identified that cardiac arrest is obviously a disastrous situation for our patients, and many patients who go into cardiac arrest, even with the best possible care, will not survive. But this is some statistics which I think in some ways are quite, it makes it seem worth it to do cardiac arrest. So we've got patients with in-hospital cardiac arrest, IHCA, and in those patients, a return of spontaneous circulation is achieved in about 53%, and a quarter of those will survive to discharge from hospital. So that still means that over 75% of people who go into cardiac arrest in hospital and received prompt CPR will still not survive. But we're doing the CPR and we're doing the cardiac arrest management to make sure that we can save that 25% of people who have the opportunity to leave hospital alive. And if you do get to leaving hospital alive, 83% had a good neurological outcome, so they were able to make a meaningful return to their previous life. So what do you do if you find an unresponsive patient? So the first responder who finds the patient needs to determine whether the patient's in cardiac arrest or whether they are unconscious and unresponsive for another reason. So they will do the normal things, which is danger response, call for help, including a defibrillator, and then they're going to look, listen and feel over the airway for a time of less than 10 seconds. So in order to look, listen and feel, you need to put your face close to the patient's mouth, turn your head and look down along the chest in order to watch the chest moving and see whether there's any normal breathing. If you don't feel breath on your face and you don't see normal breathing, then you should consider that patient is in cardiac arrest. At the same time as you're looking and feeling for breathing, you can put 2 fingers onto the carotid pulse and palpate for a pulse. So if you can feel a pulse at the same time, then that patient's not in a cardiac arrest. But if you are struggling to feel a pulse, you shouldn't keep feeling for longer than 10 seconds. You should just accept the patient's in cardiac arrest and start CPR. Fine, so while you're waiting for the defibrillator, which you've called for when you call for help, you will start CPR. And the first responder is going to continue CPR with a ratio of 30 compressions to 2 breaths. The second responder who's come to help, bringing the defibrillator, is going to attach the defibrillator as soon as it arrives and prepare for a rhythm check and shock if needed. And as more help arrives, as you saw in the video, different team members are allocated to different roles, such as airway drugs, IV access, and someone to scribe, which can be really helpful in the post-cardiac arrest situation when you're trying to make sense of what happened. So this is the algorithm which I would encourage you all to follow. So this is the Resus Council guidelines, which came out in 2021, and it tells us what to do when we find a patient who's in cardiac arrest. So now we're going to quickly talk about good quality chest compressions. So I'm just going to launch another little poll for you. And so can everyone see that poll coming up on their screen? So it asks, what is the correct rate for chest compressions in CPR? And you can select your answer. I'm going to give you 30 seconds. You've had 10. I'm expecting all of you to respond to this one. Had 16. Let's see if we can get another few responses. Okay, should we end that poll there? So we've had 18 responses. Let's see if we can get to 20. 2 more people, just click for me. I can't see who it is that's saying what, so don't worry about getting the wrong answer. It's useful revision for your exams. Okay, let's end it there. So I'll share the results. So the correct answer is what most of you picked, which is 100 to 120 beats a minute. Some people were suggesting a bit slow at 80 to 100, and some people a little bit fast at 120 to 140. And now we'll do another poll. So what depth do you think we should be pushing down to? I think this one's a bit trickier, but see what you think. Do another 10 or 20 seconds. The last few to pick an answer. Great, so I'm going to end it there. So again, most of you have got the right answer on this one. Hopefully you can see the results, and said 5 centimeters. So it's about 5 centimeters or 1/3 of the anterior posterior distance of the chest. So that's the distance from the front of the chest through to the back if the patient was lying on the floor. So if you've got a very big patient, that maybe need to be more than 5, and a very small patient slightly less. But I think probably 2 centimeters is going to be you're not going to be pushing hard enough to get a meaningful cardiac output. And pushing too hard, you're more likely to get injuries related to rib fractures and things. Generally, I wouldn't worry too much about pushing too hard in cardiac arrest. Rib fractures are reasonably common, especially if you're doing CPR on a very elderly patient, and it's not unusual to feel ribs fracturing. And that doesn't mean you're doing it wrong. It doesn't mean you're pressing too hard, and it might well mean that you're giving your patient the best chance of having a good outcome. So there's just another little video which I'm going to share with you now. And I will screen share. So this is a little video produced by the American Heart Association, and it just shows us how we can, to get the right rate of our chest compressions of CPR, we can use a musical beat in our head, because lots of people, even if they know 120 to 100 to 120 beats per minute, they struggle to actually keep to that beat. So this is just a little advert that helps teach non-doctors and non-healthcare professionals how to do CPR safely.
So, tell me, young man, do you remember what your dad and I taught you about hands-only CPR?
Yes.
Kind of.
If you see a teen or adult suddenly collapse, the first thing you do is...
Call 911.
And the second thing you do is...
Push hard and fast in the center of the chest at a rate of at least 100 beats per minute. Who even knows what 100 beats per minute sounds like?
When you get down,
remember, it's only 2 steps. Call 911.
And push hard and fast in the center of the chest to the beat of Staying Alive until help arrives.
Okay, so that's a bit of a silly advert, but I think it's quite useful for people who aren't medical to have an idea of what they can think of in their head. And there's a big problem that in pre-hospital settings, people are quite hesitant to start CPR because they don't feel they know how to do it. So that advert highlights that it's a very simple thing to do. So hand position, 2 hands in the center of the chest, which is the lower half of the sternum, 100 to 120 beats per minute, at least 5 centimeters, approximately a third of the anterior posterior chest diameter. It's important to allow complete recoil of the chest after each compression, and that's because if you don't allow the chest to recoil, the heart can't fill with blood, so you won't get a good cardiac output. As we said at the start, minimize interruptions to chest compressions and alternate the compressor duties every 2 minutes. So now we're just going to quickly talk about the next part of the algorithm, which is assessing the rhythm. So the rhythm cannot be accurately assessed while chest compressions are being performed. So you need to pause CPR to check the rhythm. As you saw in the video, timing that pause in CPR so everyone's ready and someone can feel the pulse at the same time as the rhythm check. If you detect a shockable rhythm, then you should charge the defibrillator, but do not stop CPR while the defibrillator is charging. Stop CPR only once the defibrillator is fully charged and ensure everyone stands clear prior to giving a shock. So when do we check the rhythm? So if you're in theatre, your patient is already going to be connected to ECG monitoring, and therefore you may see the rhythm as the patient goes into cardiac arrest. And in that case, if you see a shockable rhythm and diagnose cardiac arrest, then you can prepare to give a shock as soon as possible. If the patient is not connected to an ECG monitor when they go into cardiac arrest, then you should check the rhythm as soon as the defibrillator is available and everyone is prepared for a rhythm check. And then you should repeat a rhythm check after every 2 minutes of CPR. And that's regardless of whether it's a 30:2 ratio or whether it's continuous CPR with an advanced airway in place. And then the other time you should do a rhythm check is any other time if the victim becomes responsive and normal breathing is apparent, as you may have got return of spontaneous circulation. So we're going to do another quick poll of which rhythms are shockable. So let's do the next one. Hopefully you can all see that poll. So it says which heart rhythms, if detected, are shockable. Pulseless electrical activity, ventricular fibrillation, asystole, and ventricular tachycardia. And you can pick more than one if you need to. So 15 of you have voted so far. Let's see if we can get a few more. Almost there, we're on 18. Let's try and get 20 responses. So another couple of people can vote. Again, I'm not looking at who's voting what. It's just interesting to know. And it's good practice for you for your exams. Okay, it's been 1 minute and 10, so we're going to stop it there. And I will share the results. So the shockable rhythms in cardiac arrest are ventricular fibrillation and ventricular tachycardia. That's pulseless ventricular tachycardia. So as in the question, it says if detected during cardiac arrest, so with no pulse. Pulseless electrical activity and asystole are the non-shockable rhythms. Fine, so let's close that. So we're just going to quickly look at our ECG now. So you can see on the right, we've got a picture of a normal ECG complex. So the P wave is the little lump labeled P. Then we've got the QRS complex followed by a T wave. So the P wave corresponds to atrial depolarization, the QRS complex to depolarization of the ventricles, and then the T wave is repolarization. So in our cardiac arrest situation, ventricular fibrillation and ventricular tachycardia have broad QRS complexes, and that's because the rhythm is being generated in the ventricles, and any rhythm that's generated in the ventricles has a broad complex. Pulseless electrical activity could even look like a normal ECG rhythm, but is associated with no pulse, and therefore the patient's in cardiac arrest. And so that even though it looks normal on an ECG, it doesn't necessarily tell us that our patient has cardiac output. And I think that's a really key learning point here. So let's say we've detected a shockable rhythm. So that's VF or pulseless VT. I'm going to talk about what we do next. So we've covered that. So the initial rhythm is shockable in about 17% of cardiac arrests. It's pulseless electrical activity in 52 and asystole in 20%. So in the majority of time, it's non-shockable, but in these patients who have a shockable rhythm, if you can do defibrillation quickly, they have a good chance of survival. So it's really important that we are able to diagnose the shockable rhythms. So here you can see a picture of ventricular tachycardia or VT. So VT is a rapid rhythm that generates in the ventricles. It's defined by a regular rhythm with a rapid rate, usually more than 160 beats per minute, and a wide QRS complex, as I mentioned. There are two types of VT. So VT may lead to loss of cardiac output with no pulse, in which case it's pulseless VT, and that's a cardiac arrest. You need to start CPR. But you can have patients with VT who are still conscious and have a pulse. These patients aren't in cardiac arrest yet, but they're still in danger and may proceed to full cardiac arrest at any time. So if you have a patient who is in pulsatile VT, you should be getting the defibrillator ready, because if they go into cardiac arrest, you can then do a shock very quickly, restart the heart, and have a good chance that they will have a reasonable outcome. And now this is VF. So you can see in the pictures on the left of the screen, we've got some different types of VF. So the top two pictures are coarse VF and the bottom one is fine VF. So VF is an irregular chaotic rhythm. It's caused by random electrical activity in the ventricles. And so there's no coordinated movement and no cardiac outputs. All patients in VF have no pulse and will not be conscious. So these patients are always in cardiac arrest. If you see VF at a rhythm check, there's not really any point even checking for a pulse because this rhythm is not compatible with life. So if we see a patient in VF or pulseless VT, how do we perform a shock? So firstly, we should continue chest compressions as we prepare for the shock. We should minimize the risk of fire by taking off any oxygen masks or nasal cannulae and taking them at least 1 meter away from the patient's chest. If the patient is connected to a ventilator, including an eye gel, then we can leave that attached, but the anaesthetist should move away from the patient while the shock takes place. You ensure everything else is clear from the bed, so all leads and everything, no one is touching them. And then you announce to the room that you're charging, but tell the person who's doing CPR to continue to do CPR until instructed to stop. Once your defibrillator is charged, you say hands off or stop CPR to the person doing CPR, and then you deliver a shock of roughly 200 joules, and the range of acceptable shock energies is 120 to 360. Following the shock, you continue chest compressions and ventilations for 2 minutes or continuous for 2 minutes. And I'm just going to show you a video so you can see that shock being done on a real defibrillator. This is the last video, I promise.
For assessing your patient and determining that defibrillation is necessary, connecting the paddles cable to the device and applying the paddles to the patient's bare chest, set the therapy knob to the desired energy for the patient. Then press the charge button on the paddle. The orange shock buttons on the paddles flash to indicate the defibrillator is charged, and the patient contact indicator lights turn green once proper skin contact is made. Make sure no one is touching the patient or anything connected to the patient. Press shock buttons simultaneously located on the paddles. Upon delivery of the shock, the Heart Start Intrepid announces, "Shock delivered." Following successful defibrillation, the joules delivered displays and the shock counter will increment accordingly. Following successful defibrillation, and after you confirm a stable heart rhythm, return the therapy knob.
Okay. So they made a bit of a mistake in that video. Did anyone notice what it was? If you saw the mistake, tell me, unmute and tell us what you saw they did wrong. Did anyone see what they did wrong? Does anyone see what they made an error there? So they left the nasal cannula attached. So hopefully they had the oxygen turned off, but usually what we do is just remove them from the patient or remove the oxygen mask if we're in theatre at least 1 meter away. If you're moving at least 1 meter away, we don't usually turn the oxygen off. We just point the oxygen so it's pointing away from the shock. And that's a really good question on the chat. So does it mean for patients on a ventilator, you turn off the oxygen and leave the circuit attached? No, if it's a closed circuit, you can leave the ventilator and the oxygen running while the shock is delivered. It's only for open circuits where there's a risk that if there's a spark, it could come into contact with a high oxygen concentration. But in the closed circuit, there's very little leak. And therefore, even if there was a spark, it wouldn't come into contact with oxygen and wouldn't cause a fire. So that's a really good question. Okay, so now we're going to talk about the non-shockable side of the algorithm. So that's PEA or asystole. So this is asystole. So you can see there's no normal ECG complexes, but the baseline isn't entirely flat. So if there was a disconnection, that would be lead to a completely flat line, whereas asystole, there can be a slightly wandering baseline or a sort of a light wave to the ECG, but there's no normal complexes. And then this is PEA. So PEA can look very different. It can look like normal ECG complexes. It can have some broad complexes, as you see in the top picture, with some random P waves. It can have this weird sinusoid pattern that you see in the second picture, or in the third, you've got these, again, very abnormally shaped ECG complexes that look like they're ventricular in origin. So PEA can look different, and it basically means any electrical activity that is not associated with a pulse and is not VF or VT, you can call PEA. So I'm just going to repeat that. So any electrical activity that is not VF or VT or asystole is PEA. Okay, it's pulseless electrical activity, and that's a non-shockable rhythm. Fine. So in the non-shockable side of the algorithm, we look at this bottom part, and in fact for both, we look at the bottom part of the algorithm to see what to do. So you can see in the non-shockable, we go PEA or asystole, we do CPR for 2 minutes, and then we repeat our rhythm check. And we just keep going around this cycle, either on the shockable or non-shockable side of the algorithm. So doing CPR and repeating the pulse check and rhythm check every 2 minutes. And then in the bottom of the algorithm, it tells us what else we need to think about. So we need to give high quality chest compressions, which we've already talked about, and give oxygen, use waveform capnography, continuous compressions, minimize interruptions, and give get IV or IO access and give adrenaline and amiodarone, and identify and treat reversible causes. We'll talk about those things very quickly now. So waveform capnography. So we use waveform capnography, so that's end-tidal CO2, to confirm the correct position of our tracheal tube placement during CPR. Because if there's a cardiac arrest, then the end-tidal CO2 will become 0. We won't have any end-tidal CO2 because there's no cardiac output to bring carbon dioxide to the lungs to be ventilated out. But if we're doing CPR, we expect there will be some cardiac output. So we expect that the end-tidal CO2 will be present, although it may be reduced. And in fact, we can use our end-tidal CO2 to monitor the quality of CPR. So if we notice that the end-tidal CO2 is falling, that might mean that the person doing CPR is getting tired, and we need to swap them out for someone who's going to do effective chest compressions. An increase in end-tidal CO2 during CPR, so something from 10 up to 45, may indicate that the patient has a return of spontaneous circulation. So that is, their heart has started beating and their cardiac output has improved, and we're now bringing more carbon dioxide back to the lungs from the body, and so the end-tidal CO2 rises. So if that happens, it could be a sign of ROSC, and we should be aware at the next pulse or rhythm check that the patient may have ROSC, and we should feel carefully. But we shouldn't stop chest compressions based on the sign of raised end-tidal CO2 alone. We should continue chest compressions until the rhythm check. And we also shouldn't use a very low end-tidal CO2 as a value alone to decide if we should stop resuscitation. However, we know that patients who have a very low end-tidal CO2 have a less good prognosis during CPR. Okay, so we're going to do another little poll here to ask what the correct adrenaline dose is. So everyone just click what's the correct adrenaline dose in cardiac arrest in adults. So the question on the screen. So this is the adrenaline dose for cardiac arrest in adults. And I promise we're almost finished with this talk. I know it's getting late. Well done, lots of you voting, which is really great. Keep them coming in. I think 60% of you have responded, so we've got another 20 seconds. Another 10 seconds. Last few people put some votes in. You get one more vote. Okay, so that's been a minute. So I'm going to end that poll there. And I'll share with you the results. Okay, so most of you think 10 mils of 1 in 10,000, and that's the right answer. I think the adrenaline dosing can be a bit confusing when we're in an emergency. And so it's always useful to really revise these doses, because in an emergency situation, you don't want to be looking it up on your phone and you don't want to be having to calculate anything. So the 1 in 1,000 adrenaline, that's 1 milligram per mil. 1 milligram is the correct dose in cardiac arrest, but we need to give it in 10 mils because the 1 milligram per mil is a very concentrated solution and we're giving it to a peripheral vein. So we want to give a more dilute solution. So we want to give 10 mils of 1 in 10,000. 10 mils of 1 in 1,000, so that's the bottom option, that would be 10 milligrams. So that's much too high a dose of adrenaline. And then 1 mil of 1 in 100,000. So 1 in 100,000 is 10 micrograms per mil. So that would only be 10 micrograms of adrenaline. So that would be too low a dose. 1 mil of 1 in 100,000 or 10 micrograms of adrenaline is a more reasonable dose for using adrenaline as a vasopressor. So if we have a patient who's a bit hypotensive, we might choose to give them 10 micrograms of adrenaline as a bolus. But in cardiac arrest, we need to be giving them a full dose. And that would be 10 mils of 1 in 10,000. Little question coming here from Kezron. What's the disadvantage of hyperventilating a patient during CPR? So you mean, why do we keep the respiratory rate around 12? I think that's what you mean. So the end-tidal CO2 during CPR probably isn't a very good way of assessing our ventilation firstly, and that's because in CPR the end-tidal CO2 will mainly be determined by the patient's perfusion and their cardiac output than actually your ventilation. In terms of hyperventilation, we don't want to cause a very low end-tidal CO2, I guess, because remember that in the brain, if the end-tidal CO2 is very low, that may cause constriction of the blood vessels in the brain. So usually we're aiming for normocapnia, so a normal end-tidal CO2. So hyperventilation could lead to a low end-tidal CO2. I think actually in CPR it's unlikely to, because we haven't got the cardiac output to going around the body anyway to cause the overall PCO2 to be low. But there's no advantage to hyperventilating, and there may theoretically be some disadvantage if we cause the end-tidal CO2 to be low. Hope that answers the question. Okay, and when do we give adrenaline? So the dose is 1 milligram, which is 10 mils of 1 in 10,000. We give adrenaline as soon as possible in a non-shockable rhythm. So that's as soon as we find a patient in a cardiac arrest. If they're in a non-shockable rhythm on our ECG, so for most of you, if you're in theatre, you'll be able to see if they're in PEA or asystole. And remember, over 70% of our patients will be in a non-shockable rhythm. So this is the vast majority of our patients we're going to see in cardiac arrest. And these patients, we give the adrenaline immediately. So if you've drawn up your 10 ml syringe with 100 micrograms per mil of adrenaline and your patient goes into cardiac arrest on the table, I want you to pick up that syringe and give the whole thing immediately, okay? That's in a non-shockable rhythm. In a shockable rhythm, we wait until after the third shock and then we give our dose of adrenaline. We then repeat our dose of adrenaline every 3 to 5 minutes. So if we're doing a rhythm check every 2 minutes, then we can give adrenaline every other rhythm check, and that will be roughly every 4 minutes, okay? And then we're doing last poll, I think, of what the dose of amiodarone is. So should be launched now. This is the last one. So what's the dose of amiodarone in cardiac arrest? 10 of you voted, so that's really good. Keep those coming in. Do it for a few more seconds. Another 5 seconds. Great, I'm going to end it there just because we want to let everyone get off and enjoy their evening. So most of you said 300 milligrams, which is the correct answer. You will note on the next slide, so after the 5th shock, you can give a further dose of amiodarone 150 milligrams, but the correct dose for the initial bolus of amiodarone is 300 milligrams. Great. So just close that. So the dose of amiodarone is 300 milligrams, which can be given IO or IV for any patient in cardiac arrest with VF or pulseless VT after the 3rd shock. So in patients in a non-shockable rhythm, we don't need to give amiodarone at all. In patients in a shockable rhythm, we give it after the 3rd shock. And the Resus Council guidelines say that we can give a further dose of 150 milligrams after 5 shocks. And they also say that if amiodarone is not available, we should consider using 100 milligrams of IV lidocaine and a further dose of 50 milligrams of IV lidocaine after 5 defibrillation attempts. So remember, this is only in the shockable patients. So amiodarone or lidocaine are only to be used in your patients who have VF or pulseless VT, not for your patients with asystole or pulseless electrical activity. But lidocaine, which is much more readily available to us here, is an alternative to amiodarone if it's not available. Fine, so then we talked about treating the reversible causes. So I think most of you know the 4H's and 4T's, but I'm sure those of you who were there when we treated the cardiac arrest that we experienced realize that in the stressful situation during a cardiac arrest, it can be quite difficult to remember. So if you're involved in a cardiac arrest situation and the leader is going through the 4H's and 4T's and they're struggling to remember one, just shout out and give them a hand, okay? So the 4H's, we've got hypoxia, hypovolemia, hypo or hyper, which is a more common cause, hyperkalemia or metabolic acidosis, hypothermia. And then in the 4T's, we've got thrombosis, which can be coronary, so a heart attack, or pulmonary, like a pulmonary embolus, tension pneumothorax, cardiac tamponade, or toxins. So these are reversible causes. So if the cause of the cardiac arrest is hypoxia, we can treat that by putting in our tube and ventilating our patient. Hypovolemia, we give fluid or blood. Hyperkalemia, we're going to give calcium gluconate to stabilize the cardiac membranes and consider insulin dextrose to bring the potassium down, although this may be slow. Hypothermia, we're going to warm them up. For thrombosis, we can do thrombolysis. If we do thrombolysis, for example, for a PE, we then need to give it long enough to work. And generally, the advice is that if you've given thrombolysis, you should continue CPR for 90 minutes, so an hour and a half after giving thrombolysis. And that's because you don't expect the patient to get return of spontaneous circulation until the thrombolysis has caused the clot to start breaking down. So you're committing to a long period of CPR. Tension pneumothorax, as you know, we treat with needle decompression followed by a chest drain. Cardiac tamponade, so that can be treated by aspirating the blood from the pericardium and therefore reducing the pressure on the heart and relieving the tamponade. And then toxins, we may be able to reverse with appropriate antidotes. So for example, naloxone, if opiates are thought to be the cause. So those are the reversible causes we can treat after cardiac arrest has started. And then what do we do if we're successful? So this is the best outcome, isn't it, that we get ROSC. So if there is a combination of clinical and physiological signs of return of spontaneous circulation, we can consider stopping chest compressions for rhythm analysis and, if appropriate, a pulse check. So signs of ROSC would include waking, purposeful movement, arterial waveform if we've got an invasive monitoring, or a sharp rise in end-tidal CO2. And ideally, we want a number of those signs in order to pause between our rhythm checks. Okay. You may see some purposeful movement, and I've certainly seen when we've been doing really good CPR for a patient that we have seen the patient wake during CPR, but when we stop chest compressions, the perfusion of the brain reduces and the patient is still in cardiac arrest. So none of these things definitively confirm ROSC until you've done rhythm analysis and your pulse check, but these can be useful indicators. And then after ROSC, we need to do an ABCD approach, reassess our patient and work out if there's anything we need to treat. We need to keep the SATs between 94 and 98%, and we're aiming for normal PaCO2. So if the patient's intubated, we don't want to hyperventilate for them at that time. We want to keep that normal. And that's because a normal range of PaCO2 optimizes perfusion of the brain. We should perform a 12-lead ECG to look for evidence of myocardial ischemia. So that would be a heart attack. So things like ST elevation, ST depression, T-wave inversion. We should identify and treat the cause of the cardiac arrest, and then targeted temperature management. So targeted temperature management involves cooling the patient post return of spontaneous circulation to a temperature of between 32 and 36 degrees. And we can do that with active cooling. So you can put ice packs around the patient in order to cool them down. And this is thought to help with neurological recovery following cardiac arrest. And often these patients post cardiac arrest will develop a fever as part of the inflammatory and in response to the cardiac arrest. So we want to try and treat fevers really aggressively with active cooling of patients. Some of these patients will have seizures, and we should treat seizures ideally with levetiracetam, so that's Keppra or sodium valproate, and we should keep the MAP over 65 to optimize brain perfusion and the chance of a good neurological recovery. This can be a really hard thing to do, so making the decision to stop CPR. It's always difficult to know when is the right time to stop, and especially if it's a patient we know and have been involved in the care of, we often don't really want to stop because we want to see a good outcome. But if we've been performing CPR for a long period of time, then the longer we persist with the CPR, the less likely we are to have a good outcome. And even if we get the heart to start, the chance that the brain has had enough perfusion during that time for the patient to wake up and be neurologically normal goes down. The important thing, I guess, is that the decision to stop CPR should be made in agreement with all team members. So CPR should continue while the team discusses whether it's time to stop. And that should be a discussion where you confirm that you've treated any reversible causes and yet you're not seeing improvement in the patient's state. Once all team members agree, usually you will plan to stop at a rhythm and pulse check if there is no ROSC at that time. So this is a really horrible decision to make, but I'm in your careers, all of you will be involved in this, I'm sure. Fine, so on that slightly sad note, that's the end of my talk today. So these are the learning outcomes I set us at the start, and I hope we've achieved all of them, really. So we've described the causes of cardiac arrest and how we might assess them through an A to E assessment. We haven't really discussed what treatments we're going to initiate, but I've worked with many of you, and I know you're very good at treating the problems you find on A to E, and that's really the key to preventing cardiac arrest. We've talked about recognizing the heart rhythms, and you've all seen some ECGs now for VF, VT, pulseless electrical activity and asystole, and I hope you'd be able to recognize them if you saw them in your patient. We've gone through the algorithm in some detail, and I think most of you could manage cardiac arrest following that algorithm now. Most of you knew the rate and depth of chest compressions, so that's 100 to 120 a minute, and about 5 centimeters or a third, at least 5 centimeters or a third of the depth of the chest. And we've gone over the doses for adrenaline, which is 1 milligram, so 10 mils of 1 in 10,000, and amiodarone, which is 300 milligrams in cardiac arrest. And we've talked about when we administer them to our patients, both in shockable and in non-shockable rhythms. thanks for your attention. After this, I will send out a feedback survey. It's really so helpful for us if you give us feedback, because it helps us design lectures that are useful for you. So I'd love to know whether you find the polling and the quiz helpful, whether the videos are helpful, or whether you find them annoying. So things like that are really helpful. And if you tell us what you like, we'll do more of it. So definitely do the feedback so we can improve things for you. These are some references that I've used, and I will send the slides out this evening. Thank you very much. And any questions, feel free to jump in now. I'll stop sharing. And I'll put my video back on. Any questions? No questions? If there are no questions, feel free to leave. You're all, thank you for staying so late on your Thursday evenings. So there's a question come in. Some books say you give adrenaline after every 2 minutes and some say 3. So I would recommend that you follow 3 to 5 minutes, which is after every other rhythm check. So I don't know if you're getting confused, because the rhythm check is every 2 minutes and then the adrenaline is every 3 to 5 minutes. So every other rhythm check is about every 4 minutes if you do a rhythm check every 2 minutes. So every other rhythm check will give you about roughly every 4 minutes, which is within the range of 3 to 5 minutes. Hope that makes sense. On the references at the end of the slides, you can have a look on the Resus Council algorithm, but that will tell you where I've got that from. Great. Any other questions? Or any thoughts, ideas you want to share? Fine. So preservative-free lidocaine use versus anything other lidocaine in cardioversion. You know, I think if you're in the situation that you're in a cardiac arrest and you're in a shockable rhythm and you've given 3 shocks and had no outcome, I think probably any lidocaine you can access is probably the right answer to that. I think you're not going to make the situation worse by using any lidocaine you can find. By the time you're in a cardiac arrest, it's a really desperate situation. And if they've had three shocks and not responded well, lidocaine, it might be your last chance to get cardioversion. So if I could find lidocaine, if it was preservative free or not, I would use it. That's my opinion, because obviously this is a bit of a compromise. Lidocaine isn't our first choice, but that's what I would do. Any other last questions? Do feel free to leave if you've not got any questions. And thank you so much for interacting this evening. I really appreciated having all of you answered the polls. So when do I decide to start with chemical cardioversion rather than electric? So this isn't cardioversion, is it? This is defibrillation. So the treatment, as I said, the drugs you give after the 3rd shock. So you're not deciding whether to do electrical or chemical cardioversion. You're adding drugs to your shock that you've already given. Does that make sense? So this is different to cardioversion. So cardioversion you're doing in peri-arrest arrhythmias, but in, someone's on HTTP.
Mike, can I?
But yeah. So you give the amiodarone, sorry, hopefully you can see my screen, after the 3rd shock, and then you continue giving shocks at the rhythm check if you have a shockable rhythm. So while you have a shockable rhythm, you defibrillate the patient, you give them a shock every time you get to a 2-minute rhythm check. But after the 3rd shock, you add amiodarone. And after the 5th shock, you can give a 2nd dose of amiodarone. So I hope that makes sense. Any other questions? Okay, so if there are no other questions, I'm going to stop the presentation. I've recorded this session, so I hope that's okay, and I'll send the recording out to everyone when I get a chance to do that. The slides I can send this evening. The recordings are quite big, so I might send that tomorrow. Thanks so much, everyone, and have a good evening, and see you all soon.
Doctor, about a VQ mismatch.
The VQ mismatch. So I've sent out to everyone who put their emails in on the feedback form. This evening, I sent out the recording. I haven't got the slides yet for the VQ mismatch. So they came from Dr. Yoss, but I've sent the recording to everyone who completed the feedback form. The feedback form I send tonight will also have a box for your email. So if you want to get the recording of this one, then please do pop your email in there and I'll send it out to you this evening or tomorrow. Anything else? Last chance before we close. Ellie, are you saying you didn't receive the recording?
No, I didn't receive. I think I didn't receive.
So I got emails back, I think from Godwin and maybe John, saying that they'd received it, and Ezeron and Sharon who'd received it. So I think if you didn't, maybe you didn't fill the feedback in. If you filled the feedback in and put your email, then I sent the recording to everyone whose emails were there. So you can have a look and just check you filled in your email on the Zoom form and send me a message later, Ellie, and we can sort it out, okay?
Okay, doctor.
Okay, I'll make sure you get it. And I will send all these recordings to everyone eventually. It's just I'm prioritizing those who've done the feedback for us first, and then I will make this available to everyone because this is a useful learning resource. Okay. All right, thanks very much, everyone. Good evening. I'm going to end the meeting now. All right, bye then.